Okay, we're going to be talking about a few chronic obstructive pulmonary diseases. We'll discuss emphysema and compare it to chronic bronchitis, and then we'll introduce you to bronchiectasis, which isn't really much of a disease. It's more of like a secondary issue that develops. So COPD is a group of chronic respiratory disorders, primarily emphysema and chronic bronchitis. So we'll compare these two together. It causes irreversible and progressive damage to the lungs. Debilitating conditions that may affect individuals' ability to work. It can lead to the development of cor pulmonale. Again, we've seen this word a few times. It's right-sided heart failure. And then respiratory failure may occur. It is destruction of the alveolar walls and the septae. It leads to large, permanently inflated alveolar air spaces. Okay? Some of the contributing factors are genetics, cigarette smoking, and some pathogenic bacteria. In terms of genetics, there's a deficiency of alpha antitrypsin. And what this does, it inhibits proteases released during inflammation. So if we don't have this, then we have these proteases released during inflammation. If the breakdown of the alveolar wall can result in the loss of the surface area for gas exchange, the loss of the pulmonary capillaries, and the loss of elastic fibers. Those three are the biggies. Loss of surface area for the gas exchange, loss of the pulmonary capillaries, and loss of the elastic fibers. So that when you get air inside, there could be difficulty in the recoiling or the rebounding to push the air out. When fibrosis takes place, that narrows the airways, it weakens the walls, and that too interferes with passive expiratory airflow. So again, difficulty in exhalation or pushing out the air. Progressive difficulty again with expiration, air trapping, and increased residual volume. So the residual volume is when you inhale and then you exhale. Air trapping and increased residual volume is the air that's left after full exhalation. Overinflation of the lungs to the point where you get this fixation of the ribs in a respiratory position where there is an increased diameter from front to back. And it creates this visual appearance of a barrel, like a wooden barrel. So they call it a barrel chest. So here on the left-hand side, this is a normal chest. And when you see this increased anterior to posterior distance, this is a barrel chest. The musculature in between the ribs, the intercostals, are just overly developed because they're trying to force air out. In advanced emphysema and loss of tissue, this is still part of the pathophysiology. The adjacent damaged alveoli coalesce and they form large air spaces. A pneumothorax occurs when the pleural membrane surrounding these large blebs, they rupture, and then air escapes into the space around the lungs, creating a pneumothorax, where a lot of air is surrounding the lungs and can compress inward. Hypercapnia becomes marked. That's when there's high CO2 and low oxygen. Hypoxia becomes the driving force of respiration. Frequent infections, that's a big thing that we see with emphysema, frequent infections. And then pulmonary hypertension and cor pulmonale, which is the right-sided heart failure. It can develop in the late stage. So you can get dyspnea. That occurs first on exertion. So as they're trying to do something physically demanding, it's difficulty for them to breathe. Hyperventilation with the prolonged expiratory phase, right? It's just really hard for them to get the air out. So they develop that barrel chest that we showed you before. There could be anorexia and fatigue with weight loss. And then something that's very interesting called clubbed fingers that we see with a lot of pulmonary issues. Let me show you what that looks like. We see this. This is called clubbed fingers or clubbing of the nails. Treatment is mostly supportive with emphysema. You want to avoid the respiratory irritants, immunizations against influenza, so flu shots and pneumonia shots. Again, pulmonary rehabilitation is very helpful. They will do the appropriate breathing techniques to help these individuals. Adequate nutrition and hydration. This can improve the energy levels and resistance to infections. Things like glutathione, zinc, even vitamin A, very, very beneficial. Vitamin C, bronchodilators, antibiotics, and oxygen therapy as the conditions advance, right? Sometimes you'll see people walking around with these oxygen tanks and the tubes up their nose to help drive in the oxygen. And then lung reduction surgery is sometimes needed. So here's a normal alveoli. Here's the respiratory bronchial. Here's the alveolar duct. And then each of these are alveolar sacs. Here in emphysema, you could see that there's loss of septae, right, the divisions between each of them, and the capillaries, and there's decreased surface area. We have a loss of elastic fibers, so the recoiling mechanism is decreased, and you simply get these overinflated alveolus. That's with emphysema. And you get this air trapping phenomenon where normally, air comes in, and then as the pressure builds up, you get this recoiling of the elastic tissue, and then it pushes the air out. Here, when the air comes in, you get the alveolar stretching, and you get the loss of the elasticity. It becomes overinflated, and they have trouble or impaired ability to expire, right? You get that barrel chest type of deformity. Okay, chronic bronchitis. This is a daily productive cough for 3 months or more in at least 2 consecutive years. There's typically a history of cigarette smoking or living in urban or industrial areas. Here, the mucosa is inflamed. It's swollen. There's hypertrophy and hyperplasia of the mucosal glands. There's fibrosis and thickening of the bronchial wall. There's low O2 levels. There's severe dyspnea, fatigue. There could be pulmonary hypertension and cor pulmonale again, or that right-sided heart failure. There's a constant productive cough. It kind of sounds like a smoker's cough, right? Kind of like purulent and gurgly, that type of sound. Sometimes they call that rhonchi, very more prominent in the morning. There's tachypnea and shortness of breath, frequent thick purulent secretions upon coughing. The cough and rhonchi are more severe, as we said, in the morning. There's hypoxia, cyanosis, right? Maybe bluing of the lips, bluing of the fingernails, hypercapnia, which is high carbon dioxide, polycythemia, weight loss, again, signs of right-sided heart failure. So the treatment is, stop smoking and reduce the exposure to the irritants. Treatment of the infections, vaccination prophylactically for influenza and pneumonia, expectorants, right, things that will allow you to cough something up and out, bronchodilators, again, chest therapy that include postural drainage and percussion techniques to break it up. Nutritional supplements are super important for this. Now, bronchiectasis is not so much like a disease unto itself. It's a secondary condition. This is irreversible abnormal dilation of the medium-sized bronchi, primarily. Again, bronchiectasis is irreversible abnormal dilation of the medium-sized bronchi. They may be saccular or elongated. It arises from the recurrent inflammation and infections. It's commonly seen with cystic fibrosis. There is a chronic cough with bronchiectasis, production of a copious amount of purulent, not only purulent, but it's foul-smelling sputum. There's rales, remember the sound with the stethoscope that sounds like you're rubbing your hair together, or rhonchi. Again, foul breath, dyspnea, hemoptysis, and then the systemic signs of weight loss, fatigue, and anemia. And the treatment, especially if it's bacterial, antibiotics, bronchodilators, the chest therapy, and the treatment of the primary condition, because remember, bronchiectasis is a secondary symptom. Okay, let's look and compare emphysema to chronic bronchitis. So the etiology of emphysema and chronic bronchitis, there's smoking involved in both of these, but the location is different, right? With emphysema, it's the alveoli. With chronic bronchitis, it's the bronchi. The pathophysiology is very important. So with the chronic bronchitis that we did, it's increased mucus of the glands and the secretion. There's inflammation, infections, and obstruction. The pathophysiology with emphysema, you lose that elasticity, right? So it's impaired exhalation or expiration. You get that barrel chest. The chest is hyper inflated. When you percuss it, like if you tap with your finger like on a drum and you percuss, it just sounds very resonant because it's filled with air. In terms of the cough, with emphysema, it's some coughing with marked dyspnea. There's constant coughing with chronic bronchitis. And when you cough, it's purulent, right? It's purulent. There's a large amount, but with emphysema, it's little. In terms of cyanosis, not so much with emphysema, right? Because remember, you can get the oxygen in, it's getting out the CO2. But the chronic bronchitis, there is cyanosis that may be visible with that. Infections are frequent with bronchitis. Again, infections are very frequent with chronic bronchitis. Some with emphysema, but more so with chronic bronchitis. And cor pulmonale is pretty common with chronic bronchitis. We're not going to compare to asthma. We did that already in the last lecture. Okay, when we return, we will cover restrictive lung disorders, vascular disorders like pulmonary edema and pulmonary embolus.